All right, welcome back to the Evidence-Based Pilates Podcast with your host, Dr. Adam McAtee. We are getting down and dirty today with lumbar spinal stenosis. So if you've ever had a client who comes in with, they'll just probably call it stenosis, and you've been unsure of how to work with them, how to keep them safe, and also how to give them an awesome Pilates session, this podcast episode is for you. And then if you love diving into this, we right now at the time of this recording, we are going through the special populations aspect of the Anatomy and Biomechanics Club. We just covered stenosis, so it was on my mind. I wanted to share it with everyone. In the Anatomy and Biomechanics Club, we go through every major muscle and joint in the human body from head to toe, as well as relevant injuries and conditions, and therefore special populations from head to toe. And here we're talking about the lumbar spine, and more specifically, lumbar spinal stenosis. If you love this stuff, you want to check it out, you can get a 2-week free trial with the link in the show notes or on a podcast or in the description here on YouTube. With that said, lumbar spinal stenosis. Now, lumbar spinal stenosis is within the category of low back pain. And low back pain is a very broad and tricky condition, and really just a tricky category to work with. And a lot of times, there will be this simplification of low back pain in the sense that it's either specific or it's non-specific. But there's actually it's called a diagnostic triage. There's actually 3 kind of buckets of where we put individuals with low back pain. You have specific low back pain, and you also have non-specific low back pain. But then in the middle of that, you also have what's called radicular syndromes, and that's where lumbar spinal stenosis lives in. And just for clarity, the diagnostic triage, right? There's one bit of low back pain that has specific low back pain. That is otherwise known as red flags. That's things like a fracture. That would be like cancer, cauda equina, infections, things where they need to go into the healthcare system, in which it's either like a fracture that would be musculoskeletal injury, but outside of that, it's usually not musculoskeletal. With that, that's less than 1% of individuals. So it's good and healthy to screen for red flags and know how to do so. We go over that in the Anatomy and Biomechanics Club. Now, within that, that's like less than 1%. Then we have like 90 to 95% of low back pain is considered non-specific. Non-specific low back pain is where it is assumed to be of musculoskeletal origin. So we've ruled out red flags. We don't think the back pain's referring from your kidney or something like that, which is out of the scope of a Pilates instructor. And then there's also no reliable clinical tools to go ahead and specify why someone's low back is hurting, regardless of confidence. There just isn't there isn't sufficient evidence to support these clinical tests that are commonly done, like an SIJ mobility test would be a classic example for a test that is not clinically valid, but is very popular. So there's these categories, and then in the middle, it's like 5 to 10% is ridiculous. These are radicular syndromes. These are when someone is having like low back pain and leg pain, for example. This would be radicular pain, radiculopathy, spinal stenosis. That would be in I put a paper in the show notes on the diagnostic triage. Those are the 3 examples that they give. And there are many reasons why someone could have radicular pain, radiculopathy, or even just referred pain. Pain is weird. There's a lot of reasons why someone can have it, but one of those reasons could be stenosis. And stenosis can also be from other things. And that's why I want to talk about this today. So in order to really discuss lumbar spinal stenosis, it's really useful to understand what lumbar spinal stenosis means. Because when you bring meaning to words, that's the difference between memorizing something and then actually learning it. Okay. And then when you learn something, you understand it. And when you understand something, you can speak to something with more confidence, and you are more clear on the direction you're going with the client, or you have more clarity on why it's unclear as to why you can help them. I'd love to say science has all the answers, but that's not true. With that said, lumbar spinal stenosis. Lumbar refers to the low back. that would be like L5 to L1, or if you're unfamiliar with those contexts, that would be like between the pelvis and the ribs, right? So we're kind of like talking about like that general area, right? And then lumbar spinal, right? It's just referring to that part of the spine. But stenosis isn't just the condition. Stenosis, the word stenosis just means narrowing. It doesn't tell you what is narrowed, why it's narrowed, or how it got narrowed, anything like that. Stenosis just means narrowing. So it's generally referring to a space that has a certain amount of space or diameter, and that diameter has been reduced because some structure is either bigger than it normally is, or it's where it's not supposed to be, quote unquote. And so lumbar spinal stenosis literally means that there is a narrowing somewhere in the lumbar spine. It does not tell you specifically what is narrowed. And that's key for us to understand. And before I went to physical therapy school, I didn't understand that at all. And I wish that somebody told me, because life would make a lot more sense. Okay, this condition, because it is a narrowing, it is thought to be degenerative in nature. Okay, it's almost always a degenerative cause, right? Now there are different types of stenosis. Just to throw stuff out there, meaning that you could have a stenosis. Or there are different causes of stenosis. One cause of stenosis could be what's called a spondylolisthesis. I'll have to do an episode on that one too, because that one's pretty interesting. There's what's called ischemic spondylolisthesis, which actually happens in adolescence from individuals. There's always genetic components to things, but it's thought to be due to like high torsional activities such as gymnastics. And if you have, like, say, like a grade 3 spondylolisthesis, that means a big spondylolisthesis. That wouldn't be considered degenerative in like a 15-year-old, right? It might be due to their sport. So there are times where like stenosis may not be degenerative, but it's thought to be, at least in the older population, which is who we usually see this in, generally degenerative. Now, that's important to know when we talk about the exercise later on, because sometimes it's like, are we exercising to fix something, or are we exercising to manage symptoms? And when you're talking about degenerative conditions, it's almost always the latter. We're managing symptoms, improving quality of life, and all the things. But before we go down an exercise route, I want to provide more clarity on the different types of lumbar spinal stenosis. There are like two main types. You could go into three if you wanted to, but I think it's good enough for us as Pilates instructors to understand two main types. There's what's called central canal stenosis and lateral foraminal stenosis. Someone could say like, oh, what about, lateral recess stenosis? Yes, technically as well. But we'll get to the same destination if we just split it up into two. So central canal stenosis, lateral foraminal stenosis. Now, central canal stenosis refers to a stenosis in the spinal canal, also called your neural foramen. Because anatomy just has more than one word for so many things. But anyways, so it's a narrowing in the spinal canal. The spinal canal houses a lot of things. And the most important thing I would say is your spinal cord. So if you have a narrowing in the spinal canal and it creates irritation, we're now irritating the spinal cord. And that can create big problems. Okay. And then, so the spinal cord is where you get all of your sensory and motor information coming from the brain down the spinal cord into what's called the peripheral nervous system, which is like all the nerves of like your lower extremities, for example, they come from your lumbar spine. So if you have an irritation around the lumbar spine, around the spinal cord, or in the cauda equina somewhere, it can create leg symptoms on both legs, both of them. Okay, the left and the right, because the nerve roots that generate your spinal nerves that go down your legs, they originate from the spinal cord. And if the spinal cord is irritated, you can see it on both legs. It's not always, right? Not always. But if you see like nervy symptoms on both legs, that leads you to believe there's something going on in the center. The center meaning where the spinal cord is at. If you're unfamiliar with like neural symptoms, neural meaning pertaining to the nervous system or the spine in this case. Um, what that would be if we want to simplify it, like radicular pain and radiculopathy would be two common things. Radicular pain, you could think of it as like the nerves are turned on too high, right? There's like too much going on there. So you can have like an allodynia where it's like like hypersensitivity, things that used to not hurt, hurt, right? That could be an example. It could be like sharp shooting pain, could feel like electricity going down the leg. Those would be examples of like a radicular kind of symptom where the nerves are kind of turned on too much. Radiculopathy is the opposite of that. It's like they're dimmed too low. I like to think of it as like a traffic jam, meaning that the signal from the spinal cord is not making it to its destination because there's a traffic jam somewhere along the way. This could be seen as like numbness or like tingling, like a decrease of sensation somewhere along the leg, and that can become a big problem. Like if you can't feel your feet, right, you don't have protective mechanisms against like ulcers and therefore infections. It can also be motor weakness. Now, motor weakness meaning the muscles are not as strong. And now this isn't like I'm just kind of deconditioned and I'm out of shape. It's like when you're walking, your foot drops. It's called a foot drop. So that's a classic one of like severe neurological symptoms. So this can occur in a lumbar spinal stenosis, which is why I want to make this clear. Like this is not non-specific low back pain. This is not the person who just like moved house, they lifted up their couch, and like now their back is sore for 4 weeks. No, like 100% empathy to that individual, you know, who has the non-specific low back pain going on. But this is a different thing. Okay, this is not the same animal. That could occur in both sides with the central canal stenosis. Now a lateral foraminal stenosis is in what's called the lateral foramen. Okay, you could also call it the transverse foramen or just I don't know. There's other terms that's not coming to my mind, but there are other terms that describe this. But the lateral foraminal stenosis would be a stenosis that is actually happening on the side of the spine where the nerve roots come out. So it can be creating like an impingement, some irritation such as inflammation, or maybe an autoimmune response that is irritating the nerve. And that the nerve root creates the spinal nerves, which go down one side. So with the lateral foraminal stenosis, you usually see symptoms on one side, like radicular pain, radiculopathy on one side. But then you can get more nuanced, and if we want to talk about referred pain, it can go to like the other butt cheek or something. But it's usually, I guess I'd feel safer to say it's more dominant on one side, and it's usually a little bit more specific. Now, why does this matter so much, right? Well, one thing, if your client is like doesn't have a diagnosis or anything, like maybe they don't like doctors and have had that, we're in the United States, maybe they don't have health insurance, right? Or they just like they have an appointment, but they can't get in for 4 weeks, and they're having these like new leg symptoms. It's good to know something, right? We're not here to diagnose you. Like as a Pilates instructor, you can't give medical advice, but you can provide information and resources for someone to consider when they do see a healthcare provider. Now, if someone is coming in and they don't have an appointment for 4 weeks for God knows what reason, maybe the in-laws are in town, and they're having these, like they're of the population that would likely have stenosis. The mean age, by the way, would be 62 years old. So it's usually an older adult. I want to say it's female, but I'm not 100% sure on that. But it's usually older adult, like someone who would definitely be coming in for Pilates, probably more like the private session person, just anecdotally. And if they have the low back pain, and let's say they have all the signs and symptoms, which we'll go over in a moment, and they're starting to notice symptoms going down both legs, right? And then they're noticing that like their knees starting to buckle when they walk. They report like they fell twice this week. You know, for example, like you're hearing these like progressive neurological symptoms. you can bring it to their attention that this is actually more urgent than what you're referring to. I know your in-laws are in town. Is it possible for you to see your healthcare provider sooner? Meaning that if they're having if they're having worsening signs, like they do need to see somebody, and it's important for us to understand that, one, that's not normal, and then also sometimes if we're unfamiliar with these conditions, back stuff and leg stuff can seem like two different things. And then if someone has like back pain, and then they're having like a calf pain that's like sharp shooting pain, they can't feel their toes and their knees buckling on the other side. Those seem like four different things that are going on, but it actually might be due to the same thing going on in the lumbar spine. Okay? So this is where it's just good to, it's like, you can't go wrong knowing stuff, right? Now, when you know stuff, like, be fluid in your knowledge, translation, and all that, meaning don't get attached to ideas too much. But I hope this is useful. So lateral foraminal stenosis, more likely to be on just one side, and it's usually going to have, like, if it is really causing an issue, it'll probably be with some leg pain going on as well. Central canal is likely to be on both sides. Central canal would be on both sides because it is irritating the spinal cord. Lateral foraminal stenosis is likely irritating a nerve root. Now, within that, reasons why this occurs varies. It can actually be like a disc degeneration can lead to osteophytes, and then the osteophytes are taking up space in the lateral foramen. Disc degeneration is like structural and compositional changes that occur over time, which are normal aging. But when that happens, our biomechanics gets altered, and it could create different kind of stresses on the bones, creating an osteophyte. An osteophyte is a bony growth that happens due to stress, right? Our body adapts to what it's exposed to. And if we're exposed to some stresses on a certain part of a bone, you could grow an osteophyte. If that osteophyte is in a space like in like the central canal or in the neural foramen, it's possible that it could be contributing to nerve irritation, right? And so it could be creating a stenosis because an osteophyte takes up space. Okay, it takes up space. And then we may have symptoms going down the side. Now, what's important to know is, like, there's no exercise to get rid of an osteophyte, and that osteophyte can still be there. And then, 9 months later, and then your client might be out of pain. So tissue doesn't have to change for pain to change. They're two wildly different things. But you can have soft tissue changes, bony changes, degenerative changes. There are all kinds of reasons why a stenosis can happen. A stenosis is a result of something creating a narrowing, right? So you could have what's called a posterolateral disc herniation. That means you're having a disc herniation. It's going to the posterior side, but to the side a little bit, which is the most common type, because that's where there's less support. That's one reason. And then because, let's say, the nucleus pulposus comes, it's pushing against the annulus, which is like that tire-like structure on the outside of the disc, and it's creating a narrowing in the lateral foramen. That's a posterior lateral disc herniation creating stenosis, and then you're getting let's say a sciatica right down the leg. And so when your client comes in and they're like, I have a disc herniation, I have stenosis, and I have sciatica, right? It's like, well, it's just like these are all part of the same thing, right? They could be all asymptomatic. The sciatica is not asymptomatic, but you could have stenosis and a disc herniation, no pain, right? But if someone's coming in with that pain and you see these different things, they could actually be part of the same condition. But what we'll move on to now, outside of like the nerdy anatomy, the rest of this will be less anatomical, I promise. I know on audio, or even here this video, seeing me speak, there can be a challenge to do this. But in the Anatomy and Biomechanics Club, we go through like 3D models. I pull out skeletons. I have slide decks. I got all the tools to go ahead and help you out. So you get a lot of visual aid with that. Now, for signs and symptoms is like you are either talking to somebody and they're describing stuff and you're trying to put pieces of the puzzle together to get an understanding of what might be going on. And it's not your job to diagnose, but you are allowed to hypothesize and you are allowed to know something. Um, or someone comes in and you're going to have a session tomorrow at 2 p.m. and they have central canal stenosis, right? And it's symptomatic. You can create a picture in your mind of like what probably is bothersome for them. And then also what probably will make you feel better. It just informs your programming. Notice how I use the word probably, because we're always playing with probabilities, and that's key with this. Now, a common sign and symptom remember, it's a symptomatic, okay, a symptomatic lumbar spinal stenosis, whether it be, it's usually central canal would generate this, is what's called neurogenic claudication. Neurogenic claudication is like neurogenic just means it's coming from the nerves, right? Neuro is like neurological or of the nervous system, and then genic is creation. And when we talk about neurogenic claudication, what like individuals will experience pain when they're walking, not like 1 step, 2 step, but like if they usually go for like 30-minute walks at like, let's say 3 to 5 minutes, it doesn't get attached to the number, but at a small amount of walking, they will have like pain where they have to sit down, right? It's not like, oh, I'm kind of tired, I'm winded. No, they're having like excruciating calf pain. Like they can't keep going. Okay, they need to sit down. But when they're sitting down, they get relief, right? So they get relief by either stopping, or even better if they're sitting down. They'll also get this similar pain when they're standing for extended periods of time. And regardless if you are walking or if you're standing, you're in like your natural lordosis. And when you're in your natural lordosis or you extend more, we make the holes in the spine smaller, right? And remember, stenosis is a narrowing of what? A narrowing of holes, right? The holes we're talking about is the central canal or the lateral foramen. So if you're having a problem because there's too much narrowing, positions that create more narrowing are more likely to provoke symptoms, right? We're like creating more of the problem. We're not damaging the person. It's just while you're in that position, you may experience more symptoms. It would be predictable. So if someone's coming in, they're saying, I can't go walking, like it just kills my legs, right? You can get an understanding, like more of an understanding of what they're talking about with that. But if it's like, excruciating calf pain or like burning in their calves or their feet, or sharp pain goes down, but they sit down, they feel better. Or as they mentioned, standing for long periods of time, it can just make sense with a lumbar spinal stenosis. And then with that, extension postures or extension exercises are more likely to exacerbate symptoms. Now, when I say more likely, I mean if you have 20 people with lumbar spinal stenosis, maybe 15 of them or 16 of them, whatever, like a higher, more than half, you're probably going to irritate their symptoms by doing back bending exercises, right? Think pulling straps, swan, rocking, down stretch, one leg kick, double leg kick, whatever names you like to choose for the back bending exercises. It doesn't mean you're injuring them. It means that they're having a sensory experience that is similar to that of their discomfort in their daily life. And so we're usually not really interested in that, right? It's like, oh, this is the pain you always feel. Let's recreate it. Not when we're exercising, right? Like there's a time and place for that when someone's getting an assessment in like a physical therapy clinic, right? You kind of have to recreate the symptoms to get an understanding of what's going on. But when we're exercising, it's good to know like they're likely to not really like to enjoy that. So if you're programming for someone, maybe we either don't do those exercises, or if we do, we don't do a lot of them and we lower the load, right? So we lower the stresses in that area by frequency and also by demand. So meaning like maybe do like a cat cow and see how like the cow part goes, right? You're on all fours, you flex your spine and then you extend. That's very different than just like going for a swan dive, right? Not that you would just do swan dive with anybody, but the point is that would likely be bothersome. But if you also think about it, so if someone like only 20% of adults get enough physical activity relative to the physical activity guidelines. That is 150 minutes of moderate intensity exercise plus 2 to 3 resistance training sessions per week. You can also cut the minutes in half if you do vigorous intensity exercise. But if you're having pain with standing and you also can't walk, the probability of like you doing that goes down dramatically. So it's likely that these individuals are probably not getting as much exercise as they should. So we need to figure out ways to get them moving. Now, things that make them feel better, usually, keyword usually, would be sitting, right? So if you're standing, like they, if someone told you that walking, right, that like walking, for a little bit makes them feel worse, and then they're sitting down and it alleviates their symptoms, that already tells you that sitting is probably going to be fine in your Pilates session. A lot of times when we're sitting, we are in some kind of flexion. And when you are in flexion, you're actually opening up the holes a little bit more. And when I say holes, I mean the spinal canal, right? I mean the lateral foramen. I mean the stenosis, the thing that's narrow, you're making that space bigger. So it's usually helpful, not always. In addition, flexion exercises tend to be prescribed for these individuals and encouraged. So, and this is a really good one because if someone is like of the nature of like exercise is bad for me, and they were to think of one thing with the spine that's bad, they're going to be like, oh, bending forward, right? If you ask 1,000 people, that would probably be the number one answer, right? Bending forward and picking something up. But flexion is actually what's good for this person. So you can break a lot of barriers in terms of like expanding the thought of how exercise can be really useful. So if you have someone with spinal stenosis, like you're going to want to have, you'll probably win, or you'll win more often if you program more flexion exercises and less extension exercises. Okay. And then something else that has been shown to be really useful is to have people on a stationary bike. Now, we don't have stationary bikes for the most part in Pilates, but you can encourage them to do it at the gym if they have access, or if they have access to one at home. It's a good way to get their cardio respiratory fitness up. And also that tends to keep them in flexion, and they are usually able to tolerate that. So if your client has like a Peloton or something, or just like regular stationary bike, I would encourage them to use it, because we always got to think about like the human experience of having a condition, right? And so like exercise, I know I'm preaching to the choir, but like exercise is good for you, and it has good long-term benefits, right? We have reductions in like cardiovascular disease, diabetes mellitus, right? Peripheral vascular disease, and all these other things that have like huge problems down the road, but they're usually not as motivating in the moment, right? People are motivated to get out of pain today, less motivated to reduce their chances of heart failure. Now, within that, like this can be really, really helpful for us to encourage. So not only encourage, but also give people a quote unquote permission to go ahead and do, because they're sitting down, okay, and they're usually in flexion, and they can get their legs going. Because remember, these individuals, they can't walk, so they can't jog, they can't run. Treadmill obviously is off the table. And then although they might be fine on an incline, but that's a whole different detail. And then elliptical, probably not going to work out. So just giving them an option where they can get moving can be really, really valuable for them. One last thing that I want to share in regards to exercise is that individuals with lumbar spinal stenosis have a higher chance of falls, and therefore fall related injuries. And remember that the population that typically has this is 62, right? 62 is the mean. Mean just means average. So some people are above it, some people are below it. And anyways, like any older adult, you should assess, like I'm a huge advocate for like assess their balance and do strategies to improve it. One of those strategies, which can be controversial if you talk to smart enough people, are balance exercises. Now, you can just get someone stronger and improve their balance. But then you can also incorporate balance exercises. In the Pilates Club, which is another product that we have here at Evidence-Based Pilates, it's like the cost of a single group class a month, and like you get access to a ridiculous. It would be so boring for me to tell you everything that's in there, because it's so packed of stuff. You can get a 2-week free trial in the show notes. There's workshops, tutorials, and all those things. And one of the tutorials I have is how to help someone improve the balance. And so within that, you can do stationary or dynamic exercises. But one thing that I want to point out with balance exercises is that it is possible, or there's a randomized control trial that I put in the show notes, that dual task exercises may have additional benefits to single task exercises. This is a space that I'm definitely watching in the literature, but a dual task is usually when you give someone a cognitive task while they're doing a balance exercise. A balance exercise could be like a tandem walk. They do that like for DUIs, if you've ever seen someone on the street doing that. So that would be like you have like a tape or some kind of straight line, right? Like tape on the floor works great. And then you have someone walk like toe to heel, right? Like one foot in front of the other, arms can be nice and wide, whatever it is, and walk forward. But if you give someone a cognitive task, and honestly, it's like an annoying task because it hurts your brain. And that's the point, is like give them a task that is cognitively challenging. And when something's cognitively challenging, it like hurts your brain. That's what learning feels like, by the way. It's like brain fatigue. So if you ever experience that, you're just learning, right? Like it's like quads burn to get your quads stronger. Well, your brain hurts by fatigue. So an example of a cognitive task would be like count backwards from 3 starting at 72 and do the tandem walk. So that's a simple strategy. It's a specific strategy that could work just for anyone. But then when you have someone with lumbar spinal stenosis, that's just a flag where it's like, let me assess your balance and see how you're doing. But I won't go too deep into that because that could be its own podcast episode. So within this, let me just zoom out a little bit. When we're doing exercise with someone, we've got to know that, especially a condition, like what's the goal? What's the goal of exercise? The goal of exercise, like people can have specific goals, but when we're working with a condition, what are we trying to do? Okay, we're not trying to change structure here. Now, I would love it. I would love it if it's like, here are your 3 stenosis exercises to widen the gap. You'll no longer have stenosis in 72 hours. I would love that, but I would also be full of shit, right? And when I say that, sorry for the passion, but I say that because it's important to understand the limitations, and then we can have realistic expectations. And we can share those realistic expectations with the people that trust us. In other words, the clients that we have a therapeutic alliance with. So the idea with exercise and spinal stenosis is to improve symptoms, improve function, and help someone manage their pain experience, because we're really looking to manage the pain as nature takes its course. And lumbar spinal stenosis does have a favorable natural history, which means if you do nothing, right, you do nothing, it tends to get better in over half the individuals. And then if you do exercise, we can help manage the symptoms and improve function a little bit more during their healing process. So it is good to know that it does get better, right? Because sometimes when you get the stuff and you don't know anything about it, it's like you're hopeless, you're screwed. You have to have surgery or else you always have pain. Like if someone got diagnosed with Parkinson's or multiple sclerosis, like those are degenerative conditions that don't improve over time within the current day treatment. But stenosis is not that way, right? You absolutely can get better. And what's cool is like someone's scan doesn't even have to change. Okay? And that's a big thing that we can do with people, is to provide them support and education to recognize that pain is a moving target, whereas structure a lot of times moves really slow, but pain, oh, that can move really fast. Yeah, just have someone with stenosis do like swan dive 20 times in a row. You'll show them how fast pain can change. But with that said, I do want to make it clear that I'm not saying that extension is contraindicated for lumbar spinal stenosis, because it's not. It's what's called a precaution, and a precaution just means think about it, right? When we know stuff about stenosis, then we can predict that it'll probably not feel great. But sometimes we're wrong in our predictions, and that might be the one thing that your client loves, right? And then it wouldn't add up to the textbook or anything like that, but what really matters is your client's experience. So with that, the person in front of you is going to have the answers, but you can come in prepared and knowing something. And just knowing that extension is likely to bother them because it narrows the space a little bit more. then like a neutral or a flexion position can be of use. But if I were to summarize how to help clients with lumbar spinal stenosis, it would be this. The first thing is to listen to their story, because you are working with humans, not just body parts. Everyone has their story, and this is not your stenosis client. This is Janet's. Okay. Janet is a 64-year-old individual. She's been your client for 4 years. She has 3 dogs, 2 cats, as well as 4 kids and 3 grandchildren. She loves them. She shows you pictures about them all the time. She enjoys she enjoys walks on the beach, but she can't do it right now because she's experiencing stenosis, and she's looking for a professional like you to help her in her experience. Right? There's just more to the human experience, and just listening to someone's story can be part of your treatment or part of your experience working with them. Now, also understand their goals. Their goals may have nothing to do with the stenosis. The stenosis is something that's annoying to them, right? Their goals might be, to do a push-up or something like that, right? And then they just want, they want their back to feel better as well, and the leg pain. Or it could be like that the stenosis is bothering their ability, or it's inhibiting their ability to participate in hiking, or they want to do a marathon, or they just want to walk with their neighbor, right? Whatever it is, understand their goals, and then have a shared decision making in how you achieve them, or how you help them achieve them. With that, just understand that this population is more likely to have a reduced physical activity volume, and therefore tolerance. So promote physical activity. Start at a place that they can tolerate and build it up, just like anyone else. And as you do so, I would encourage flexion-based exercises just as a prediction, but they will always let you know what works best for them. And therefore, I wouldn't avoid, but I would be cautious with extension-based exercises, and really check in and see how they're doing with that. Encouraging stationary cycling is also awesome. Doing full body stretching and strengthening, just like anyone else, is highly encouraged. And the last thing that I would advocate for is to add balance exercises to their either home exercise routine that they do, or hopefully they do, right? Or I guess it'd be better to say the home exercises that you recommend, and then also challenge their balance while they are there with you. And when I say challenge their balance, I'm not talking about having them lie on their back with a squishy ball on the reformer underneath their butt and putting one foot in a strap. Not like weird balance stuff that, yeah, I'll call that weird balance stuff. I'm talking about balance stuff that will transfer to that has a higher likelihood of transferring outside of the Pilates studio. And when I think of that, I think of weight bearing exercises, so have them vertical on their feet and challenge their balance in that manner, in addition to everything else. And if anything's going to help their balance, it's probably going to be getting freaking stronger. And individuals with lumbar spinal stenosis are adaptive and anti-fragile, just like anyone else. And I hope that this podcast and this video, if you're watching on YouTube, was useful for your skills, knowledge, and your confidence. And if you appreciate this content, you will love the Pilates Club and the Anatomy and Biomechanics Club. You can go ahead and get a 2-week free trial to either one of these in the show notes. And if you choose the Anatomy and Biomechanics Club, guess what? You get the Pilates Club as well. So the Anatomy and Biomechanics Club actually comes with all of the Anatomy and Biomechanics Club plus the Pilates Club. You will have so much content, you won't know what to do with it. Okay, it's an incredible resource. And in the mission of evidence-based Pilates is to provide affordable science-based education to Pilates instructors to build their skills, knowledge, and confidence. And with that said, enjoy your day, and I'll see you in the next one.